It's a 56-year-old male patient, Hindu, and a vendor by profession from Mirzapur in Uttar Pradesh, presented with the chief complaints of lump in the right side of the abdomen since past 3 months and stools mixed with blood since 3 months. There is loss of appetite since 3 months, and there is a right-sided abdominal pain since 1 month. Coming to the history of present illness, patient was apparently normal 3 months back. Patient noticed a lump in the middle of the right side of the abdomen 3 months back while taking a bath. The lump was non-tender. Initially, the lump was small in size. Roughly, he gives the size of a coin and progressed to the present size within 3 months. There is no history of lumps elsewhere in the body. During defecation, patient has noticed stools mixed with dark red-colored blood for the past 3 months. The amount of blood was small in quantity and painless defecation. Initially, the blood in stools was noted at intervals of 5 to 6 days, but since last 1 month, the dark-colored blood was noted with every defecation. The patient also noticed a loss of appetite for the past 3 months. There was also associated easy fatigability in doing routine daily activity since the past 3 months, for which he was evaluated at a local hospitals and had 3 blood transfusions in the past 2 months. He also gives a history of weight loss, an approximate weight loss of 10 kgs in past 3 months. And the patient also noticed a low-grade dull aching pain in the right lower quadrants since 1 month. This was relieved on medication. There was a pain-free intervals in between. There were no aggravating factors, and there is no radiation or migration of pain. There is no relationship with food intake. There is no associated nausea and vomiting. There is no history of evening rise of temperature. There is no history of constipation, diarrhea, or mucus in the stools. There is no history of jaundice, no history of generalized abdominal distension postprandial, and no history of any urinary complaints. There is no history of cough, expectoration, and dyspnea, and there is no history of any bone pain. There is no history of any altered sensorium also. Coming to the past history, the patient has never complained of similar complaints in the past. He has no history of tuberculosis. He doesn't give any history of hypertension, diabetes, asthma.
Just a moment, Vijay. Why history of altered sensorium?
Ma'am, to rule out systemic spread to cerebral system, ma'am.
Okay. How do you think it is connected with your present history, making it more relevant?
To rule out any systemic spread of particular pathology which I'm suspecting.
What kind of brain metastasis will give rise to altered sensorium? That's what Dr. Mallika wants to know.
How common it is?
What is the common presenting feature of a brain metastasis?
Headache, sir, vomiting, intractable vomiting, headache, and
projectile vomiting it is.
Projectile vomiting and specific motor losses.
And what is the commonest cause of altered sensorium?
Sir, dyselectrolysis is the most common cause of altered sensorium.
So what are you expecting here?
Sir, hyponatremia or
sorry, why hyponatremia? Yes, any history of vomiting?
No history of vomiting, ma'am. Like it can be any paraneoplastic syndrome.
You are just shooting in the dark.
There is no history of vomiting. There is no history of diarrhea.
So what are the tumors in which paraneoplastic syndrome is seen? Do you see that often in colon cancer? That is what you are expecting?
No, ma'am. Colon cancer, it is very rare.
Then, what are the cancers frequently associated with CNS?
Renal cell carcinoma, ma'am. Small cell lung cancer.
The small cell lung cancer should have been your first answer. You're not expecting that.
Coming to the past history, he has no history of similar complaints in the past, no history of tuberculosis, and there is no history of hypertension, diabetes, asthma, myocardial infarction, and stroke. Coming to the treatment history, he doesn't give any history of any drug intake, particularly anti-tubercular drugs, steroids, anti-diabetic, and anti-hypertensive medication. There is no history of any surgical or medical intervention.
Any other common drug intake which will lead to discoloration of stool?
Iron medication, sir.
Yeah, so any iron supplements that you should ask in case you have you feel dark colored stools or something like that.
Yes, sir.
So what is the theory behind this dark colored stool? Why it becomes that colored?
Acid hematin is the responsible thing for the dark colored stools. No?
Okay. And where does the acid hematin formation takes place?
Actually, acid hematin is when the bleed is from the upper GI bleed, sir. secondary to the gastric secretions.
This is a lower GI bleed.
Yes,
Will
ma'am.
you
I
have
mentioned as
colored
dark
stools?
red colored stools, Miss May. He mentioned stools mixed with dark red colored blood, ma'am. Altered blood, not the fresh red blood, ma'am.
So that's what I'm wondering. Then how it is a lower GI bleed then?
Patient described the symptoms as blood and stools,
Yes, sir.
or he just described black stools or
Stools.
dark colored stools.
Dark red color. Dark colored stools, no, sir. Specifically, I've asked him, like, he felt it was very altered blood. Like, it doesn't look like a fresh blood, but very dark red, maroon color, actually, he told, sir.
Last time also when we had a case of rectal bleed, I specifically said that you have to be very careful when you are eliciting a history because your diagnosis will depend upon what kind of a bleed it is.
Yes, sir.
So you have to differentiate a melena from a fresh blood mixed with the stool.
Yes, sir.
Understand that?
Yes, sir.
That is the first thing that you
Actually,
should try to do the moment patient says that I have a bleeding. You
yes,
have to differentiate it that what kind of a bleeding does he have? Does he have a melena? Does he have a hematochezia or does he have a stool mixed with blood mixed with stool?
sir, it's mostly a hematochezia, sir.
Now you're changing your
You're
statement.
changing your statement.
I'm sorry, I've changed it. Hematochezia, no, ma'am. I'm sticking to this thing, ma'am. It's stools mixed with a dark red colored blood, ma'am. It is not fresh blood, and dark red colored blood is also like mostly seen in proximal colonic or lower distal small bowel bleeds mostly. No, ma'am, it is never a hematemesis. Sorry, ma'am, hematemesis, ma'am.
Yes.
No,
This
ma'am, no, it was
bleeding
there is never associated hematemesis in the same patient, ma'am.
or any vomiting.
No, ma'am, no episode any vomiting, ma'am. Mentioned in the history, there is no vomiting or nausea in this patient. Coming to the personal history, is married with 3 children, normal sleep pattern, there is no history of allergies, he takes mixed diets, and there are no addictions. Family history is born out of a non-consanguineous marriage.
एक मिनट पीछे जाओ. I'm not very sure if we should say normal sleep pattern and all this. Is it necessary?
Well, I would not comment upon sleep pattern, but I would definitely comment upon addictions. This is not a word that I want to hear in personal history. Because that there is a question for Vijay. What's the difference between habits and addictions?
And this is tell me. We are taught in pharmacology.
It's a physiological dependence on particular substance. Both physiological and physical dependence is addiction.
So basically, what you want to say by no addiction is that patient is a non-tobacco user and non-alcoholic.
Non-alcoholic, yes, sir.
So when they are called habits and when they are called addictions.
When there is a physical and physiological dependence on a particular substrate without which he'll not be able
No,
to.
you tell us in layman language what it means.
Addictions like without the particular alcohol or smoke, whatever he's taking, he will not be able to do his routine activity, ma'am.
No.
There is a physical dependence and physiological dependence on.
So what happens if you stop it? What is the difference between a tobacco addiction and a heroin addiction?
He will develop a withdrawal symptoms, ma'am.
When you say no addiction, it means that patient may be in habit of taking the tobacco or alcohol.
Yes, sir.
But he has no addiction. So he may be taking tobacco and he may be taking the alcohol. Isn't it?
Yes, sir.
But he is not addicted to it.
Yes, sir. I got it, sir. I will mention that he's not a smoker, neither an alcoholic.
You better know the difference between the habits and addictions.
And don't mention sleep pattern unless it's really relevant.
Jeevan.
In a completely coherent person who,
so which are the cases? Which are the cases, or what are the complaints where sleep pattern becomes important? What complaints patient would have? Where would you like to know whether the patient has a normal sleep pattern or not? Patient presenting with what complaints will have a disturbed sleep pattern?
So patient having any severe pain or
Sir, in obstructive jaundice, patient if complains of itchiness or if there is a progressive rise of bilirubin.
More common manner?
Any intractable pains?
Urinary complaints. Respiratory complaints. Patient who present with urinary or respiratory complaints will probably have more disturbed sleep pattern because they may have to go to toilet multiple times, increased frequency, or dyspnea. So if you have a history of dyspnea or a increased frequency, Disturbed sleep pattern is possible. If you have a chronic intractable pain, sleep pattern is important. There you expect the sleep pattern to be disturbed. But otherwise, sleep pattern per se has nothing to do with making a diagnosis. It is a surrogate for a symptom.
Coming to the family history is born of non-consanguineous marriages, and there is no history of similar complaint in any of the family members, and there is no history of any malignancy in the family members, and there is no history of tuberculosis in any of the family members. Summarize my clinical history: a 50-year-old man with no history of malignancy, family history of malignancy, with a 3-month history of progressively increasing lump noticed on the right half of the abdomen, stools mixed with a dark-colored blood. There's a loss of appetite and easy fatigability in doing daily activity, with a weight loss of 10 kgs and blood transfusions, and 1-month history of right-sided dull aching abdominal pain, which was relieved on medication.
So you cannot add these lumbar and hypochondrium and all this in history.
No,
because
ma'am,
that is
this-
something which patient is
Yeah.
telling you. Yeah, you are right.
Yeah.
You are right.
Okay.
They are just reiterating it.
General examination, the patient was explained about the examination procedure and was examined initially in sitting position in a well-lit room under full privacy after taking consent. Patient was conscious, alert, oriented to time, place, and person. ECOG score of 1. Pallor is present. BMI of 18.3, and BP was 130/80 on right arm in supine position. Pulse rate was 85 per minute in right radial artery with regular rhythm, normal volume, febrile. Respiratory rate was 15, and thoracoabdominal and regular. There is no icterus, clubbing, generalized lymphadenopathy, and pedal edema. The examination, local examination of a lump. The patient was made to lie on his back with legs extended. The area between nipple and mid thigh is being exposed. And the patient was examined from side, then tangentially, and finally from either side of the bed. Inspection, the abdomen was scaphoid, and there is a single irregular shaped lump of approximately 6 into 5 centimeters was noted in the right lumbar region. The skin over the swelling was normal. The edges were irregular but well defined. The lump did not move with the respiration. All the quadrants were proportionately moving with respiration. The umbilicus was central and inverted. No visible peristalsis or pulsations were noted at the time of examination. No visible or dilated veins were noted. Hernial sites were intact on cuff impulse. Inspection of scrotum was normal. No fullness was noted in the left supraclavicular fossa. On palpation, the inspection findings were confirmed, and on palpation, the abdomen was soft, and there was no tenderness or there was no local rise of temperature. A single lump palpated in the right lumbar region was noted measuring 6 into 5 centimeters in size, irregular in shape, nodular surface, margins are well defined and irregular, hard in consistency. Coming to the location of the upper margin is 5 centimeters from right subcostal margin at the mid-clavicular line, and the lower margin was 11 centimeters from the right subcostal margin. The medial margin is 5 centimeters from the midline at the level of umbilicus, and the lateral margin is 10 centimeters from the midline at the level of umbilicus. On palpation, there was no pulsation, the lump was not pulsatile, and the overlying skin, there is no pitting noted on the overlying skin. There is no movement noted with respiration. Swelling is not mobile in any direction. On left lateral position, the lump did not fall forward. The mass was not palatable, neither not bimanually palpable. On the leg rising test and shoulder rising test, the lump has become smaller.
So what is the first thing you should test on palpation of any abdominal lump?
Tenderness and local rise of temperature, ma'am.
So have you mentioned it?
Yes, ma'am. First, ma'am. On palpation, abdomen was soft. There is no tenderness and no local rise of temperature, ma'am. Leg rising test and shoulder rising test, the lump has become smaller. The liver and spleen were not palpable. No similar masses were not palpable. There is no guarding and rigidity. No expansile cough impulse noted at the hernial sites. No renal angle tenderness noted. Testicular examination was normal, and no palpable node in the left supraclavicular region. The dullness was noted over the right lumbar mass, but rest of the other quadrants were resonant. The liver dullness was noted from the fifth intercostal face to costal margin in the mid-axillary line with a span of 12 centimeters. There is no shifting dullness noted. On auscultation, the normal bowel sounds were present at the time of examination. There is no bruit or venous hum heard. On digital rectal examination, after taking consent and in SIMS position, on inspection, there were no anal tags, sinuses, or ulcers noted. And on digital rectal examination, the sphincter tone was normal, no growth was palpable, or no blood stain was noted. Examination, cardiovascular system, normal S1, S2 heard it with no added sounds. Respiratory system, there is bilateral air entry present with no added sounds. CNS intact, higher mental functions, and no focal deficits noted. Spine and back examination was normal. To summarize my case history, a 50-year-old male with 3-month history of progressively increasing lump, noticed in right half of the abdomen, stool mixed with dark-colored blood, loss of appetite, easy fatigability in doing daily activity with a loss of weight over 10 kgs, and history of blood transfusions, and 1-month history of episodic right-sided dull aching pain, abdominal pain which relieved on medication. There is no clinical symptoms of systemic disease. Failure was present on systemic examination, and on local examination, a 6 into 5 centimeters hard, irregular, well-defined with well-defined margins, non-tender, right lumbar fossa mass noted, which cannot be bimanually palpable, diminished in size on leg raising test, with no mobility on respiration and dull on percussion noted. There were no clinical signs of any systemic disease. With this, I had a provisional working diagnosis of malignant ascending colon mass with no clinical features of systemic metastasis.
So was the lump mobile side to side?
No, ma'am, there is no mobility, no intrinsic mobility, ma'am, in any direction, ma'am.
You don't have a differential diagnosis?
No, ma'am, I have no differential diagnosis, ma'am. Ma'am, one rare differential diagnosis I would like to quote, ma'am. Any retroperitoneal tumor infiltrating colon can be a second differential diagnosis, ma'am.
So what did you miss in your examination? Say right lumbar mass. So when you
Yes,
have
sir.
a mass in the lumbar region, what else you should look for?
Sir, urinary complaints were ruled out, sir, in the history. Sir, examination, the mass was not bimanually palpable. Renal angle tenderness and was not noted. Renal angle fullness was not noted. And ballotomal movement is also not seen, sir.
To palpate the upper border clearly?
Yes,
Your
ma'am,
hand
it was
could
clearly
move
palpable.
between the
Yes,
costal
ma'am.
margin and the lump?
Yes, ma'am, there's a 5 centimeter distance between the costal margin at the mid-clavicle line to the upper margin, ma'am.
Okay, so what will you do now?
So with the suspicion of malignant colonic mass, initially I want to confirm my diagnosis.
Satyavijay, can this be a inflammatory lump, inflammatory mass like tuberculosis or something like that?
Sir, I ruled out the
What,
tuberculosis.
how can you say it's malignant ascending colon mass?
Yes, sir. Like both the cases share a history of chronic malnutrition, but there is no history of personal history of tuberculosis, or there is no contact with any.
Need not
history of
be, need not.
tuberculosis.
That is not mandatory.
And there
of
is
any-
no evening rise of temperatures or night sweats. And even on clinical examination, it is a well-defined hard lump, sir. Colonic mass probably it's not hard lump.
I feel you should keep it as a differential.
Very unlikely in a lumbar area. It could be a cecal mass, cecal tuberculosis, ICR region, but a lumbar mass is.
In a lumbar mass, the possibility of it being a tuberculosis is very less.
You should keep a retroperitoneal tumor as if anybody stresses you. It could
Yes,
be.
But then that will not have the blood-stained stools.
Yeah, then only if somebody stresses on that. You don't have NDD, then.
Yeah.
Hold up cecum. It's a tuberculosis. It will rise above, will go into the right hypochondria or lumbar regions. So,
Oh yes,
usually
you are right. In a pulled up
cecum.
cecum, it will go. But what makes the mass in ileocecal tuberculosis? Cecum or ileum?
Sir, actually, it's a conglomerated mass which develops.
Where does tuberculosis occurs? In the ileum or cecum mainly?
Terminal cell ileum, sir.
Terminal ileum. Is terminal ileum retroperitoneal or it is intraperitoneal?
Intraperitoneal.
So what is the mobility of the terminal ileum? This is a retroperitoneal mass which has no mobility. Ileocecal tuberculosis or a ileocecal mass will have some mobility. They will not be fixed masses.
And that can be some tenderness also.
Yeah, there could be tenderness also.
Because it's a low-grade inflammation. And majority of these people will have certain degree of ascites. In this patient, in PR, you did not feel any nodules here and there, no?
No, ma'am. Yeah.
Sir, can this be a Crohn's? Can we consider Crohn's as a differential diagnosis for this patient or any inflammatory bowel disease?
So what is the history you will get in patients with an inflammatory bowel disease?
Sir, mostly they
Will they have a long history?
Yes. They have a long history and they have bleeding with dark stool.
And then whether there are recurrent episodes or it's a solitary episode?
Sir,
For a patient to present with such a big.
Mostly recurrent episodes, ma'am, in inflammatory
You don't
bowel
have
disease.
such history.
And what
don't have
happens to
such-
bowel movement, Menak?
Your bowel movement, mostly the bowel movement is increased with recurrent blood mixed stool, sir.
So there is no history here. No? So in an inflammatory bowel disease, the presentation is by increased frequency.
And recurrent episodes.
Recurrent episodes. So what will you do?
I would like to confirm my diagnosis, sir, in the same patient. So I'd like to proceed with the colonoscopy and biopsy, the contrast enhanced computed tomography, both IV and oral contrast of thorax, abdomen, and pelvis, with a baseline investigation and cancer-specific investigation of CEA, sir. In the same very patient, the colonoscopy showed an ulceroproliferative growth noted in the hepatic flexure and ascending colon. The scope could not be negotiated beyond the growth, and the biopsy came out to be a moderately differentiated adenocarcinoma. And the CT showed a large ill-defined nodular mass of 11 into 10 into 9 centimeters, which is a circumferential thickening involving ascending colon and hepatic flexure. The luminal narrowing is present, and pericolic fat standing is noted. Abutment noted with the second part of the duodenum.
It's
Multiple
better
enlarged
to show your findings on the scan.
circumferential masser, and this the below image I wanted to show that cecum was free in the pelvis part. It was loaded with stool, and sagittal section showing a mass circumferential with the luminal narrowing. Fat standing was noted. Pericolic fat standing was noted. Multiple pericolic lymph nodes were noted. Chest examination was normal. Normal thorax study was there. Liver was normal. With the CT findings, I would like to have my final diagnosis of adenocarcinoma of ascending colon, clinical C stage T4A and 2 M0, stage 3C.
What was the
So,
C level?
So yes, sir. On the routine investigations, hemoglobin was 8.4 and albumin was
They
3.
should have come before the diagnosis.
Sir, initially I wanted to confirm the diagnosis, sir. Later, as a workup, sorry, sir, I should have kept it in the early thing. CE was 337 nanograms per milliliter.
The baseline hematology and biochemistry is irrespective of diagnosis.
Yes, sir.
So this is something which you do in all patients. They should not come after the diagnosis. They should come first.
Yes, sir. Yes, sir.
The hematology and the biochemistry should always come first. Okay, so what are you going to do now?
Pregnancy and CT features showing of complete high chance of complete resection. I would like to go with the upfront surgery, sir. And the surgery will be right hemicolectomy, which with complete mesocolic excision. And as there are multiple pericolic lymph nodes, I would like to have a central venous ligation or D3 lymphadenectomy in this patient.
Will you do a right hemicolectomy or an extended right in this?
According to Japanese classification, ma'am, like more lymph nodes, I would like to go with a hemicolectomy, ma'am.
I'm not sure if you will get a good margin. Such a big tumor, 11 centimeters.
Yes, ma'am.
With cecum free. What is the role of neoadjuvant therapy in locally advanced tumors like this?
Ma'am, neoadjuvant chemotherapy in colonic malignancies is there is no as such a trial, ma'am. There's a trial called
No, there is a
Foxtrot
trial.
Yes, ma'am. There's a
And then-
Foxtrot trial, ma'am. It's a only trial which showed a there on giving neoadjuvant chemotherapy, the tumors can be downgraded, but on long term, 2-year failure rate was similar in both patients where the neoadjuvant was given and no neoadjuvant was given. It's a kind of negative
It was-
trial, ma'am.
No, it's a very young trial. It's only a 2-year failure rate
Yeah, 2-year
has been
failure rate.
reported. And what
Yes,
was the histological regression in these patients?
Ma'am, 17% there was a histological regression, ma'am, in the patients.
No,
Sorry, ma'am, 17% has progressed, ma'am, and
59% patients had a good response.
good response. Sorry, ma'am, 17% have progressed, ma'am. I'm so sorry.
Put the positive thing. So it's the role is coming up.
Yes, ma'am. Upcoming, ma'am. It's upcoming the role of both for radiotherapy also, ma'am. They're also trying for T4 unresectable tumors. They're also trying neoadjuvant radiotherapy, ma'am. Still under investigation, ma'am.
So how do you decide the extent of colonic resection? Your lesion is at the ascending colon and hepatic flexure, and then you say that you will do a right hemicolectomy. So how
Recent
do you
Japanese
decide?
classifications. Recent Japanese classification, sir. Like 10 centimeters on either side of the tumor can be resected, so that maximum number of pericolic lymph nodes can be retrieved.
What is the number of lymph node that you want to retrieve, and what is the
Minimum of 12 lymph nodes have to be retrieved in resection.
and how much of the colon has to be excised to retrieve 12 number of nodes minimum?
If the procedure is that to complete mesocolic excision, it includes all the mesocolic lymph nodes and also
What is the minimal bowel length that you have to resect to get minimum 12 lymph nodes?
at least 10 centimeters to 20 centimeters. Sir.
It is 30 centimeters. And how do you decide whether you are going to do a right hemicolectomy or you are going to go beyond and do extended right hemicolectomy?
Sir, if it is a transverse colon growth and uh, adequate margin is not possible, like with hemicolectomy, then we would proceed with right hemicolectomy, sacrificing the colic artery.
So how will you decide adequate margin? See something on the CT scan and tell me whether you will be able to get a margin with the right hemicolectomy or not. So when you saw the CT scan, you didn't look for the vessels.
Yes, sir. I've seen for the vessel, sir. Like
Show me how far the tumor is from the middle colic artery. What is the
probably
distance? What is the distance between the edge of the tumor and middle colic artery? What happened?
sorry, sir. Not able to appreciate middle colic artery in the picture. Sir. Like,
So on what basis did you plan for a right hemicolectomy?
based on CT, as it is involving mostly ascending colon and chances of hepatic flexure are.
And going on to, if you look the picture on the left, it is also going on to the transverse colon.
So it's actually the mass that is being shown, sir. Like, if it is extending into the transverse colon, I would like to go to extended hemicolectomy, sir.
You have to tell me whether it is extending there or not. You have to show
As
me.
per, like, sir,
What's the
in
point
this,
of showing me a CT if you cannot plan on it?
yes, sir. In this, I'm not able to show, but transverse colon was free in the CT in the video, like which I've seen, sir. Like,
If you are not able to demonstrate, then how will we know?
this particular very picture I could not appreciate, sir, but the transverse colon was free in the other sections of the film, sir.
You should have kept a picture on the basis of which you could plan your excision. You have to justify why do you want to do a right hemicolectomy.
Yes, sir.
If your lesion is involving the hepatic flexure and if you go 10 centimeters, how far away is your middle colic artery from hepatic flexure? So basically, if you read, you have again not read DeVita. I'm sure you have read NCCN guidelines have come here. I've told you to read DeVita. DeVita has a very good picture showing the tumor location and extent of surgery. For the
Right
tumors
branch
which
of
are located, on the hepatic flexure, ideal is to go for a extended right hemicolectomy. The problem is that you people are not reading. You think NCCN will give you everything. Even surgical planning NCCN will give you. Your primary source is DeVita and other books of like Robin Smith, operative surgery books. For AJCC, you have to read AJCC manual. And for the treatment guidelines, you have to see NCCN. So you have to read all four. If you are not going to read all four, how are you going to plan your treatment? Like extent of surgery, you cannot determine based on what you are showing me. I cannot decide based on these pictures whether I am going to do a right hemicolectomy or extended right hemicolectomy. But my DeVita tells me that if the lesion is located on the hepatic flexure, it should be extended right hemicolectomy.
You ligate the middle colic artery, where will you translate the bowel?
Ma'am, at the junction of 2/3 and 1/3, 2/3 on the right and 1/3 on the left. Ma'am.
I think only a 5 centimeter margin is what we used to read is enough. I'm not sure. Please check it.
It's
Dr. Pandey
actually,
says it's 10 centimeters.
no, it's not 10 centimeters. Actually, the total bowel length that is required to get a minimum 12 samples is supposed to be around 30 centimeters.
Achha.
Because in colon cancer, the minimum number of lymph nodes that you are required to harvest is 12.
True, but I mean the length of normal bowel that has to be excised, that is about 5 centimeters.
That is fine. You can have a 5 centimeter margin. But you see,
Yes, exactly. That's what I meant.
you can have a 5 centimeter margin on the transverse colon, but the 5 centimeter margin on transverse colon will bring you to middle colic artery. As far as the proximal margin is concerned, proximally you have to take out the ileocecal junction. Then only it will be an anatomical resection.
Is it okay, like if I can on that regarding this length, sir? There's extensive studies being made by Japanese on regarding the extent of resection, sir. They're classified into 4 types, sir. Like if there is a source feeding vessel can be identified, 5 centimeters distal from the bleeding vessel and 10 centimeters from the tumor. They felt it is adequate amount to be resected for the adequate number of lymph nodes, sir. And if there are like a single feeding vessel, 10 centimeters on either side of the feeding vessel, they thought it is sufficient for the collection of adequate number of lymph nodes. And if there
Beta,
are two vessels,
what are the feeding vessels in this area?
middle colic and
Middle colic and ileocolic.
ileocolic, yes, right colic and
So these are the two feeding vessels.
yes,
And that is the question being asked. See, you cannot leave the cecum behind. So if you have to take
yes,
out the cecum,
yes, sir.
now the question is how far you are going to go on the transverse colon. That is the question being debated. And that will depend upon whether you have to ligate the middle colic artery or not. Because if you ligate the middle colic artery, you have to go 2/3 of the transverse colon. This is what you need to decide on CT scan before you go for the surgery rather than taking a decision on the table. What's the point of doing the imaging if you have to take all the decisions on the table? You have to do surgical planning beforehand. Na?
Yes, sir.
You have done a right hemicolectomy. Now, what are
Yes,
the
sir.
things that you are going to look for in the reports, pathology reports?
Just before that, suppose what will be what will be your steps after opening up the abdomen? This is a pretty advanced disease, isn't it?
Yes, ma'am.
So
I would
you
like
have
to.
done a laparotomy, then what will you do?
Yes, ma'am. I would like to rule out any evidence of systemic metastasis, any peritoneal metastasis, liver metastasis, and I would like to see whether it is locally advanced then by mobilization, whether it is any adherence to the ureters or renal gerotas fascia or duodenum or
So would you start with mobilizing the tumor,
Geo.
or you will approach with a central venous ligation?
No, ma'am. I would like to start mobilization, ma'am, because I wanted to rule out whether the mass is whether R0 resection is possible or not.
Anything else will you do before mobilization? Any fluid you collect?
Ascitic fluid cytology is being sent. If ascites is present,
So what happens even if you do a R0 resection, and but there are not R0, I would say, there are subtle peritoneal deposits.
ma'am,
You're
if
able to remove
entire
the tumor.
yes, ma'am, if the entire thing can be removed, there is a role of intraperitoneal chemotherapy, ma'am, IPEC, ma'am, with the 5-fluoro is not yet proved with like there is any
Like
R0 resection.
intraperitoneal or a HIPEC? What is the
HIPEC,
definition of
ma'am.
HIPEC?
Not HIPEC, ma'am. No, hyperthermia is not being used, ma'am, here. Only intraperitoneal chemotherapy with 5-fluorouracil is being used. Because HIPEC with oxaliplatin did not show any 5-year overall survival or disease-free survival. Other than that, 5-fluorouracil intraperitoneal chemotherapy has shown a benefit in the patient.
Before that, something else will you do before doing whatever?
Complete R0 resection has to be done. No residual disease has to be there.
So what it is called in a patient who has a peritoneal spread?
Debulking? No, not there is no role of debulking, ma'am. It has to be R0 only.
Chalo, let's come to the tumor what Dr. Pandey was asking. You read it. Some
Varun,
other time we'll discuss.
I have a couple of questions. What all vessels will you take while doing a right hemicolectomy? What all vessels will be ligated?
So ileocolic, right colic, and right branch of middle colic, sir.
Along with the corresponding veins.
And along with the corresponding.
Will you take the omentum? Will you take the omentum?
Yes, sir. Omentum also will be included, sir.
Whole of omentum?
Up to 1/3 of the omentum, sir.
Is there any guideline or is it described anywhere like this?
Sir, I've just read that omentum is being removed, sir, but extent of omentectomy, I'm not very sure, sir, whether it is 2/3 or 1/3 from the.
Suppose no omentum is absolutely not involved.
But
It's
still, it
a
has to be
ascending
removed. It's in a transverse colon growth, it has to be removed, sir. Or hepatic fracture or transverse colon, it has to be removed.
What's the rationale for removing the omentum in any surgery?
Ovarian malignancy, sir. Stomach malignancies, gastric malignancies.
So why do you remove it in stomach?
Sir, the vascular supply and the along with lymphatics of the particular organ flow along the omentum, sir.
So do colonic lymphatics traverse through the omentum?
So transverse colon.
Do lymphatics of transverse colon traverse through the omentum?
No, they don't travel, sir. They won't travel, sir.
So in colonic malignancy is only taken as a margin.
Yes, sir.
Whereas in gastric malignancy, it will be taken as a part of lymphatic drainage. Like sir asked you, what will you look for in the postoperative specimen?
Initially, I want to confirm the diagnosis, sir, and I would like to see the radial margin.
Why do you
proximal
want
and
to
distal.
confirm the diagnosis now? What is the
Considering-
difference between diagnostic pathology and surgical pathology?
Sorry, sir. I was just confirming the same diagnosis, sir. Initial diagnosis and.
What is the
No, you should
difference
never say
between
that.
anatomic pathology, surgical pathology, and diagnostic pathology?
I should not mention as confirmed, sir. Like I'll see the histopathology. I should have told. Like,
Which guidelines do you follow to see the histopathology report?
sir, American College of Pathology, the CAP guidelines, sir.
College of American Pathologists.
Sorry, College of American Pathology.
So what are the things that you look for in a colonic malignancy?
So, yes, sir. Histopathological diagnosis.
Surgical pathology.
Yes, sir.
Don't talk of diagnostic pathology. You already have a diagnosis of adenocarcinoma.
Yes, sir.
Now talk of surgical pathology.
Yes, sir. Extent of growth, sir. The layers involved in the bowel and margins, sir. Radial margin, proximal and distal margin. Number of lymph nodes retrieved. Lymphovascular invasion. Tumor budding and tumor deposits. If by any chance a patient has received any neoadjuvant chemotherapy, response to the chemotherapy, number of lymph nodes retrieved, and out of the number of lymph nodes retrieved, how many of them are positive?
What are the molecular classifications of colorectal cancers?
Sir, colonic malignancies are they are divided into 4 types: sir. MSI high type and canonical type, metabolic type, and mesenchymal type. Sir.
How do you characterize them?
Sir, based on the MSI MSA pattern, BRAF pattern, WNT signaling, and lymphocytic infiltration, and SCANA gene, sir, SCNA gene. IHC for MSI, sir, either PCR or IHC for MSI. Yes, can be done, sir. Like.
Okay, you have a T4A disease here, stage
Yes,
3.
sir.
So patient will require adjuvant therapy.
Yes, sir.
How will you choose the adjuvant therapy?
Sir, as it is a stage 3C cancer, sir, I would like to have an adjuvant therapy for 6 months. My option will be either Folfox or Capox, depending upon the patient's ability. If patient is he's able to, sir, there are a few things I would like to take. I wanted to see whether the patient is compatible, whether he can tolerate having both oral and IV medication, pre-existing any. If he is able to tolerate both oral and IV medication, I would like to go with Capox and or modified Folfox 6 regimen. Sir. The patient duration will be 6 months of duration. Modified Folfox 6 will be a 2-weekly regimen, and Capox will be a 3-weekly regimen.
Can you tell me about some randomized controlled trials that you have heard of in adjuvant therapy for colon cancer?
So Mosaic trial is the main trial that was responsible for adding oxaliplatin for the 5-fluorouracil, which has been being used since past, sir. Also CUSAT trial, sir, which was supporting adjuvant chemotherapy in stage 2 malignancies. And I would also like to.
What is the indication of MSI testing in NCA colon?
Sir, recent NCCN guidelines are advocating MCA testing in all the patients irrespective of age, sir.
Does it change the management? Will you test
Sir.
MSI in this patient?
Yes, sir. MSA will be tested in this patient, sir. MSA testing will be useful in stage 2 malignancy also, because stage 2 MSI, if their patient is high and with low risk factors, they are not subjected to any adjuvant chemotherapy. And if MSI, they are stable, and with low risk factors, they are subjected to either 5-fluorouracil or capecitabine. And but if they are MSH stable and with high risk factors in stage 2, they are subjected to either 3 months of Capox or 6 months of Folfox. Sir. And even in MSI is being useful in these patients, like actually stage in stage 2 it is much useful, sir. Like if it is MSI high, there is a relative resistance to 5-fluorouracil, so they cannot be given. It should not be given alone. It should be added with any auxiliary platinum.
So in this stage, it's of prognostic significance, whereas in stage
yes,
2,
stage 2, yes, and in stage 2 and 3, it's prognostic, sir. More than predictive for
What are the indications of Folfox? Any regimen modified 6 or whatever in stage 2 disease?
Sorry, sir.
In stage 2, when will you give Folfox?
Sir, when the patient is MSI stable and having high risk factors, that can be less than 12 lymph nodes being retrieved, or lymphovascular invasion, or poorly differentiated malignancies, or if there is any perforation or obstruction, sir.
So, can you tell me which was the trial which shows that cetuximab is not effective in adjuvant setting
So, cetuximab is not
compared to Folfox6?
Yes, sir. Cetuximab is not a drug in
Which was the
1, 2,
trial?
3.
Which was the trial which shows that cetuximab is not effective in adjuvant
If
setting?
I'm not sure. Crystal trial.
No, it's intergroup
Sorry,
147.
intergroup 0147. Sir.
0147. And which trial showed that bevacizumab is not effective in adjuvant setting?
NSABP 07.
No,
Some number I'm not sure, sir. Like
no, no.
NSABP.
C08. Okay.
Which is the only cancer where bevacizumab is effective in adjuvant setting?
Ovarian, sir.
Right. Ovarian cancer. What are the common side effects of oxaliplatin?
Sir, peripheral neuropathy is the main side effect of oxaliplatin, and
Anything which is characteristic of oxaliplatin toxicity or
blue liver syndrome, sir.
oxaliplatin?
Sinusoidal liver disease.
That is not okay, fine, but other drugs also cause it. Something which is characteristic of oxaliplatin.
And peripheral neuropathy, sir.
Yeah.
Peripheral neuropathy is seen with all platinums
All platinums, yes, sir.
and taxane.
Sinusoidal liver disease. Blue liver is the
Pharyngeal disc is here.
okay.
It gives you alter. I mean, some of I've not seen any patients report it, but I've of course read it, which is characteristic of oxaliplatin.
Peripheral hand-foot syndrome, sir. Or,
Hand-foot syndrome? No.
sorry, sir, that is for capsaicin.
That is for capecitabine. That's for capecitabine.
What is the mechanism
Yep.
of action of 5-FU?
The primary pyrimidine synthase inhibitor, sir.
Which one? What does it inhibit? Which enzyme?
DDP, sir, dipyridamole.
How will you follow up these patients?
As it is, if I'm thinking if it is a pathological stage 3 disease, sir, I would like to have a physical examination of the patient every 3 monthly for first 2 years.
So, wait a minute. One question I'll ask all the residents, which I think I was asked or I've seen a lot of examiners asking. Can you trace the lymphatics of this malignancy from colon to a supraclavicular node? How will this malignancy spread to supraclavicular node? Can you trace the lymphatic pathway?
Yes, sir. From the pericolic lymph nodes through the principal artery lymph nodes via middle colic and
Right.
vessels,
Then
and to the paratic lymph nodes. From there to the cisterna chyli, and left to thoracic to the supraclavicular.
Right. So some of the examiners ask this from all the abdominal malignancies trace the lymphatics of that. So fine, you continue with how will you follow up this patient?
Yes, sir. As it is a stage 3 disease, I'm assuming it as a pathological stage 3 disease. Like patient will be having a physical examination every 3 monthly for first 2 years, along with CE examination every 3 monthly. And if the patient has as this patient has undergone colonoscopy, I would like to do a repeat colonoscopy at the end of 1 year, and I would like to have an yearly CT imaging for 5 years. Sir.
Vitamin D and celecoxib.
Sir, there are no proven roles of vitamin D and celecoxib. So there are trials. There is a BCCI trial showing that celecoxib has no advantage in slowing down tumor recurrence. There is no role of vitamin D also, sir. Like there is no proven role, sir. Actually, it's still under studies. Actually, vitamin D is suspected to cause the decrease of cell growth, decrease cell proliferations. That was a suspected. It's a mechanism they are thinking for vitamin D as a.
Okay, sir. I mean,
Vijay, can you tell me about the syndromes which are associated with colon cancer?
I would like to initially start with hereditary non-polyposis colitis, HNPCC, sir, and familial adenomatous polyposis syndrome are the two main syndromes I would like to tell, sir.
What else?
Sir, there are autosomal recessive syndromes also like MYH associated disease and PAPP associated polyposis, sir, and SMAD So and the hematomatous polyposis syndromes like Peutz-Jeghers and juvenile polyposis syndrome.
Basically, you classify them as syndrome with adenomatous polyps and
Yes, sir.
syndrome with atypical
Polyps.
polyps.
Yes,
So
sir.
what are the
Adenomatous
syndromes with adenomatous polyps?
So, syndromes with adenomatous polyposis are HNPCC and FAP, and MYH associated polyposis are adenomatous polyposis syndrome.
What is Gardner's syndrome?
Sir, Gardner syndrome is a variation of FAP, sir, which has osteoids and desmoid tumors.
What is Turcot syndrome?
Turcot syndrome is also a variation of FAP with brain tumors, sir.
Okay.
And HNPCC is due to MSI instability, and FAP is due to 5pq21 gene mutation with the VNT pathway abnormality.
And what are the ones with the atypical polyps?
Sir, Peutz-Jeghers is due to P10 mutation, sir. And
No.
sorry, STK11, sir.
STK11. Okay.
And Cowden is P10 gene mutation, sir.
Yeah, where were we? Juvenile polyposis syndrome. यार अभी तो तुमने P10 Cowden बताया है.
Sorry, sir. P10 Cowden के लिए, sir. I'm not sure, sir. Like juvenile polyposis syndrome.
It's primarily SMAD4.
SMART4, sir. SMART4 or DCC.
And what about hereditary mixed polyposis?
Group of genes, sir. I remember like
Okay, tell me the clinical presentation. Don't tell me genes.
hereditary polyposis. Sir, I'll start with FAP, sir. FAP usually presents with multiple polyps.
That you have said. I just want to know about atypical. I know you know about the typical adenomatous polyps.
Yes, sir.
Peutz-Jeghers, Cowden, juvenile polyposis.
Yes, sir. Peutz-Jeghers usually present with hematomatous. There is a perioral mucoid pigmentation, hematomatous polyps, hematomas. Sorry, hematomas, and
Hematomas or hematomatous polyps?
hematomatous polyps.
So which disease has hematomas and which one has hematomatous polyps?
Hematomatous polyps are in Peutz-Jeghers syndrome, sir. Hematomas are present in Cowden's disease, sir.
And they are also present in juvenile polyposis.
Juvenile polyposis, yes, sir.